Every morning, the same ritual. You open the pill organizer, pop the tablet, wash it down with coffee, and move on with your day. You have been doing this for years. Maybe your doctor switched you from one medication to another at some point and never fully explained why. Maybe you are on two of these drugs at the same time and nobody told you how they interact inside your body. Amlodipine, hydrochlorothiazide, Metoprolol. These are three of the most commonly prescribed blood pressure medications in the United States. Tens of millions of seniors take at least one of them every single day. Here is what concerns me as a physician with 15 years of clinical practice. Most patients who sit across from me cannot tell me what their medication actually does. They do not know which organ it targets. They do not know what side effects to watch for. They do not know when to be genuinely worried. They swallow and trust. That trust is not enough. Subscribe and hit like right now. What you are about to hear, nobody is going to explain at your next appointment. There is no time and there is no revenue in it. Help Dr. Johnson reach 100,000 subscribers. Every single one counts. Today I am going to walk you through all three of these drugs, how each one works inside your body, what nobody warned you about, and the specific signs that mean you need to talk to your doctor immediately, not next month, this week. But before we touch the medications, you need to understand the machine they are trying to fix. Because without that context, nothing about these drugs makes sense. After 50, your blood vessels change. This is not opinion. It is measurable, predictable physiology. The smooth muscle fibers in your arterial walls gradually stiffen. A protein called elastin, the material that gives your arteries their flexibility, slowly gets replaced by collagen, which is rigid. Your arteries, which once expanded and contracted like soft rubber tubing with every heartbeat, increasingly behave like hard pipes. Now picture a garden hose. When the hose is flexible, you can push water through it, and the walls absorb some of the force. The flow stays smooth. But if that hose turns stiff, the same amount of water creates much higher pressure against the walls. Nothing about the pump changed. The pipes changed. That is exactly what happens in your body. Your heart is not pumping harder. Your vessels can no longer absorb the force. Pressure rises. When your doctor reads two numbers off the cuff, here is what they actually mean. The top number, systolic pressure, is the force your blood exerts against the artery wall at the moment the heart contracts and pushes blood out. The bottom number, diastolic pressure, is the pressure that remains in the arteries between beats while the heart rests and refills. In younger people, both numbers tend to rise together, but after 50, a specific pattern emerges. The top number climbs while the bottom number stays the same or even drops. Doctors call this isolated systolic hypertension, and it is the dominant form of high blood pressure in seniors. It happens precisely because stiff arteries cannot expand to cushion the systolic surge. Here is the part that changes how you think about this. Blood pressure is not just a number on a chart. It is a mechanical event happening inside your vessels, roughly 100,000 times every single day. Every beat either protects or damages the inner lining of your arteries. That microscopically thin layer of cells called the endothelium, when pressure is controlled, that lining stays smooth and intact. When pressure runs high, beat after beat, day after day, it chips away at that surface like water hammering against a riverbank. This is the context your doctor does not have time to give you in a 12-minute office visit, and without it, the medications you are about to learn about make no sense. Let us start with the first of the three, amlodipine. Your doctor may have called it a calcium channel blocker. That name sounds complicated, but the mechanism is straightforward. The smooth muscle cells that wrap around your arteries need calcium to contract. Calcium ions flow into those cells through tiny channels in the cell wall. The muscle fibers tighten, and the vessel narrows. Narrower vessel, higher pressure. Amlodipine blocks those calcium channels. Without the calcium signal, the muscle relaxes. The vessel opens wider. Lower resistance, lower pressure. Simple physics. Now here is what your doctor probably did not spend time on. The side effects that patients experience every day and almost never connect to this drug. The most common one is ankle swelling. Most people assume this means they are retaining water. That is not what is happening. Amlodipine dilates the arteries, but the veins do not dilate at the same rate. That mismatch increases pressure inside the tiny capillaries of the lower legs, and fluid leaks out of those capillaries into the surrounding tissue. The ankles puff up. It is not a kidney problem. It is a plumbing mismatch. and it is the single most common reason patients stop taking amlodipine without telling their doctor. Beyond the swelling, many patients report dizziness when standing up, flushing, and headaches in the first few weeks, and a lesser-known effect, gum overgrowth, where the gum tissue gradually swells over the teeth. One critical fact about amlodipine that changes how carefully you need to handle it. This drug has a very long half-life. It stays active in your body for 30 to 50 hours. If you miss a dose, you may not feel a difference for an entire day. But if you forget whether you took it and double up, those two doses stack. Blood pressure can drop dangerously low. And one interaction that catches seniors constantly: grapefruit juice. Many people over 60 drink it every morning, believing it is healthy. Grapefruit contains compounds that block the enzyme in your gut, responsible for breaking down amlodipine before it enters your bloodstream. Drink grapefruit juice with amlodipine, and significantly more of the drug gets absorbed than your doctor intended. Your carefully measured dose effectively becomes an overdose. If you are on amlodipine, grapefruit is not a health food, it is a risk. Now the second drug, hydrochlorothiazide. Most patients know it as my water pill and assume it simply makes them urinate more. That is a dangerously incomplete understanding of what this medication does inside your body. Hydrochlorothiazide works at the level of the kidney. Specifically, it targets a structure called the distal convoluted tubule, a section of the tiny filtering tubes where your kidneys decide what to keep and what to discard. Normally, sodium gets reabsorbed back into your blood at that point. Hydrochlorothiazide blocks that reabsorption. The sodium stays in the urine, and wherever sodium goes, water follows. More sodium in the urine means more water in the urine. Blood volume drops. Less volume pushing against the vessel walls. Lower pressure. That part is straightforward. Here is the part most doctors mention once, in passing, and patients immediately forget. Hydrochlorothiazide does not just flush water. It flushes potassium, magnesium, and sodium in unpredictable ratios. Potassium is not a minor nutrient. It is the mineral that keeps your heart beating in a regular, coordinated rhythm. When potassium drops below a critical threshold, a condition called hypokalemia, the electrical signals in your heart become unstable. The heart can develop dangerous, irregular rhythms. This is not a theoretical risk, it happens. And here is what makes it insidious. The early symptoms of potassium depletion are the exact things seniors blame on getting older. Muscle cramps, especially at night. A fatigue that does not match your activity level, weakness that comes out of nowhere, dizziness that appears and disappears without explanation. These are not aging, these are electrolyte depletion, and they are your body's early warning system. There are two more effects almost nobody warns patients about. Hydrochlorothiazide can raise blood sugar levels and uric acid levels. That means this one drug can quietly push a patient who is already pre-diabetic across the line into type 2 diabetes territory. It can also trigger a gout attack, sudden severe joint pain, most often in the big toe, caused by uric acid crystals forming in the joint, and during the summer months, the risk compounds. Seniors on hydrochlorothiazide who are out in the heat are losing fluid through sweat and through the drug simultaneously. The combination can produce dangerous dehydration far faster than either factor alone. Dehydration causes dizziness. Dizziness causes falls, and we already established what a fall means after 60. The third drug is metoprolol. This is a beta blocker, and the mechanism is different from the first two. Your body produces adrenaline, the hormone that accelerates everything. Heart rate goes up, force of contraction goes up, blood pressure goes up. That is useful when you are running from danger. It is not useful 24 hours a day, 7 days a week. Metoprolol blocks the adrenaline receptors on your heart. With those receptors blocked, the heart beats slower and with less force. Less force per beat means lower pressure against the artery walls. For many patients, this drug is genuinely life-saving. But metoprolol comes with a set of effects that profoundly impact daily life, and almost nobody prepares seniors for them. The first is fatigue, not ordinary tiredness. A deep, heavy, whole-body exhaustion that does not improve with rest, does not lift with coffee, and does not match how much you actually did that day. This is the number one complaint I hear from patients on beta blockers, and nearly every one of them blames it on age. It is not age. It is the pill. The second is cold hands and feet. The drug reduces cardiac output, meaning less blood gets pumped with each beat. Circulation to the extremities drops. Your fingers and toes pay the price. The third is weight gain. When you artificially slow the heart rate, metabolic rate follows it down. Patients eat the same food, do the same activities, and the scale quietly climbs. They blame themselves. They should be looking at the prescription bottle. And the fourth, the one that alarms me most in clinical practice, is depression-like symptoms. Difficulty feeling motivation, emotional flatness, a sense that color has drained from life. Patients on metoprolol report this frequently, and because these symptoms look exactly like normal aging, grief, or loneliness, they are almost never connected to the medication. The person suffers in silence, thinking this is just what getting older feels like. One absolute rule with metoprolol: never stop it suddenly. If you decide you no longer want to take it and simply quit, your heart can rebound with a dangerous spike in rate and blood pressure. This is called rebound tachycardia. Metoprolol must be tapered gradually under medical supervision. That is not a suggestion. That is a safety requirement. You have now heard how each of these three medications works inside your body. You know what amlodipine does to your ankles and why grapefruit is a problem. You know what hydrochlorothiazide strips from your blood and why those nighttime cramps are not just aging. You know what metoprolol does to your energy, your circulation, and your mood. That is important knowledge, but knowledge without action changes nothing. Most people will watch this, feel a flicker of concern, and go right back to their routine. I want you to do something different. If anything I just described sounds familiar, the swelling, the cramps, the exhaustion, the dizziness, you owe it to yourself to get properly evaluated. Care Health is a free platform that connects you with healthcare options in your area. Cardiac screenings, blood pressure monitoring programs, clinical trials for heart disease and hypertension. All you do is fill in a short form, date of birth, gender, basic information, takes about 30 seconds, and Care Health matches you with relevant options near you. No cost, no commitment. The link is in the description below, or scan the QR code on screen right now. Just open your phone camera and point it at the code. As your doctor, this is the step I would tell you to take next. Now, back to what you need to know, because there is something critical about how these drugs interact with each other that almost no one discusses. Many seniors are not on just one of these medications. They are on two, sometimes all three simultaneously. Doctors call this combination therapy, and it is extremely common in blood pressure management. There is a logic to it. Each drug attacks pressure from a different angle, so combining them can produce better control than any single pill alone. But here is what that logic does not account for. Combining these drugs does not simply add their effects, it multiplies certain risks in ways that are not always obvious, and that nobody walks you through at the pharmacy counter. Let me show you the specific pairings that concern me most. Amlodipine plus metoprolol. Both of these drugs lower heart rate and blood pressure. Separately, each one produces a controlled, manageable drop. Together, they can cause excessive drops, particularly when you stand up from a chair, get out of bed in the morning, or rise after bending down. This is called orthostatic hypotension, a sudden fall in blood pressure that makes you dizzy, lightheaded, or causes your vision to go dark for a moment. In a 30-year-old, that might mean grabbing a door frame. In a senior, it means a fall. Falls lead to hip fractures. And hip fractures in people over 65 carry a 1-year mortality rate that would alarm most patients if their doctor ever said the number out loud. Now consider hydrochlorothiazide plus metoprolol. We already established that the diuretic depletes potassium and magnesium. We also established that metoprolol slows the heart. Put those two together and think about what you have built. A heart that is beating slowly, running on depleted electrolytes. Potassium and magnesium are the minerals that keep the heart's electrical system firing in a stable, coordinated rhythm. Strip them out while simultaneously slowing the rate, and you have created a setup for arrhythmia, an irregular heartbeat that can range from uncomfortable to life-threatening. Here is the critical message. If you are on more than one of these medications, you need regular blood work, not once a year at your annual physical, at the frequency your specific drug combination demands. Potassium, magnesium, kidney function, blood sugar. These numbers need monitoring. Most patients do not know they should be asking for this. Now you do. There is another problem I see constantly, and it starts with a number that most people trust far more than they should. Your blood pressure reading. Most patients believe that the two numbers their doctor reads off the cuff are a definitive, reliable verdict on their cardiovascular health. That belief is wrong. A single blood pressure reading is almost meaningless. Your blood pressure fluctuates throughout the day by 20 to 30 points depending on stress, what you ate, how much water you drank, what time of day it is, and even which arm was used for the measurement. There are two specific patterns that make this dangerous. The first is called white coat hypertension. Your blood pressure is normal at home, but the moment you sit in the doctor's office, the anxiety of the visit pushes it up. The doctor sees a high number, adjusts your medication upward, and now you are being treated for a reading your body only produces when it is nervous. The second pattern is far more dangerous. It is called masked hypertension. Your reading in the office looks perfectly normal, the doctor is satisfied, but at home, during your regular life, your pressure runs dangerously high. This goes completely undetected because the only place you ever get measured is the one place your body happens to be calm. This is why home monitoring matters, and most people do it wrong. Here is the correct method. Same arm every time, seated for a full 5 minutes before you begin, feet flat on the floor, back supported, cuff positioned at heart level. No talking during the measurement. Take 2 readings, 1 minute apart, and average the 2 numbers. That average is your real reading. Now, the target. For most seniors, current guidelines aim for below 130/80, but this is not a universal rule. For patients over 75, or those already on multiple blood pressure medications, pushing the numbers too aggressively downward can cause more harm than the high pressure itself. Excessive lowering causes dizziness, falls, fatigue, and reduced blood flow to the brain. This is a conversation your doctor should be having with you individually, tailored to your age, your medications, and your specific risks. If that conversation has not happened, bring it up at your next visit. Now let us talk about something that is sitting in your kitchen right now, silently working against every pill you swallow in the morning. Most patients assume that once the medication is prescribed and the dose is set, the drug does the same thing every day regardless of what you eat or drink. That assumption is wrong. Certain foods and drinks change how much of the drug actually enters your bloodstream, and the results can range from the medication not working at all to it hitting your system like a double dose. We touched on grapefruit earlier, but let me explain the full mechanism because this matters. Your gut wall contains an enzyme called CYP3A4. Think of it as a security checkpoint. When you swallow amlodipine, that enzyme intercepts a portion of the drug and breaks it down before it ever reaches your bloodstream. Your doctor calibrated your dose knowing that checkpoint exists. Grapefruit contains compounds that shut that checkpoint down. The enzyme stops working. Now the full dose of amlodipine passes straight through into your blood, unfiltered. Your 5 milligrams tablet effectively becomes 8 or 9 milligrams. Blood pressure drops too far, dizziness hits, and the patient has no idea why. 1 glass of grapefruit juice in the morning can sustain this effect for over 24 hours. The second hidden saboteur is licorice, not the candy, the real thing. Genuine licorice root contains a compound called glycyrrhizin, and it does something very specific. It causes your body to retain sodium and excrete potassium. Read that again. That is the exact same direction hydrochlorothiazide is already pushing your system. The diuretic is flushing potassium. The licorice is flushing potassium. Together, they can crash your levels dangerously fast. Many seniors consume licorice root in herbal teas without ever connecting it to the cramps and weakness that follow. The third enemy is hidden salt. We have been trained to think of salt as what comes out of a shaker, but 80% of the sodium most people consume is already inside the food before it reaches the table. Canned soup, deli meat, bread, condiments, salad dressings. A single can of chicken noodle soup contains more sodium than you should consume in half a day. And sodium directly counteracts what every one of these 3 medications is trying to accomplish. Your pills are pushing pressure down. The salt in your dinner is pushing it right back up. You are fighting your own treatment with a spoon. And alcohol, even moderate amounts. Many seniors have a glass of wine with dinner or a small drink in the evening and consider it harmless. Alcohol amplifies the blood pressure lowering effect of all 3 of these drugs. Amlodipine, hydrochlorothiazide, metoprolol, every one of them hits harder with alcohol in the system. The blood pressure drop becomes steeper, especially at night when pressure already dips naturally. That means more dizziness, more instability, more risk of falling on the way to the bathroom at 2 in the morning. Nobody puts these interactions on a card and hands it to you at the pharmacy. Now you have them. Now I want you to hear something clearly, because this chapter could be the most important few minutes of this entire video. There are specific warning signs for each of these 3 medications that mean something is going wrong right now. Not gradually, not eventually, now. and you need to know exactly what to look for. If you are on amlodipine and you notice rapid, severe swelling of your ankles and feet that appears suddenly, not the mild puffiness that develops slowly over weeks, but a dramatic change over a day or two, that is a red flag. If you feel chest tightness that was not there before, or a heartbeat that feels irregular or racing, do not wait for your next scheduled visit. Call your doctor. If you are on hydrochlorothiazide and you experience muscle cramps that wake you from sleep, confusion that your family notices before you do, extreme thirst combined with very little urine output, or a heartbeat that feels like it skips, pauses, or flutters, those are signs of electrolyte depletion that has crossed from uncomfortable into dangerous. Your potassium or magnesium may have dropped to levels that threaten your heart rhythm. If you are on Metoprolol and your resting heart rate drops below 50 beats per minute, if you experience fainting or near-fainting episodes, sudden unexplained shortness of breath, or a noticeable worsening of depression symptoms, those are not side effects to tolerate quietly. Those are signals that the drug is suppressing your system beyond what is safe. Here is a simple self-check you can do right now. Place 2 fingers on the inside of your wrist, just below the base of your thumb. Find your pulse. Count the beats for 15 seconds and multiply by 4, that is your resting heart rate. If you are on Metoprolol and that number is consistently below 55, that is a conversation you need to have with your doctor this week, not at your next annual visit. And here is the overarching rule that applies to all 3 medications. If you have been stable on a drug for months or years and something suddenly changes, a new symptom appears, an old symptom gets worse, or you simply feel different in a way you cannot explain, that is not a coincidence. That is a signal. Do not adjust your own dose. Do not skip pills to see if it helps. Do not wait it out. Call your doctor and describe exactly what changed and when. Everything I have told you today is useless if it stays in your head and never reaches the one person who can actually change your prescription, your doctor. Most patients sit in that office, hear the verdict, nod, take the prescription, and leave. They think of questions in the car on the way home. They think of more questions at 2 in the morning. But in the room, when it matters, they go blank. So I am going to give you something concrete, a set of specific questions to bring with you, written down on a piece of paper or in your phone. Hand it to your doctor or read directly from it. There is no shame in that. In fact, doctors respond well to specific, informed questions. It signals that you are an engaged patient who is paying attention to their own body. That does not make the doctor's job harder. It makes it easier. Here are the questions. First, am I on the lowest effective dose for my current blood pressure, or was this dose set years ago and never revisited? Because many patients are still taking the dose they were started on 5 or 10 years ago, and nobody has checked whether a lower amount would now be sufficient. Second, when was my last potassium and magnesium level checked, and should it be checked more frequently given the medications I am on? If your doctor cannot answer that question from memory, that tells you something. Third, is my current combination of drugs still the best option for someone my age, or are there newer alternatives with fewer side effects? Medicine does not stand still. What was the best available option in 2015 may not be the best available option today. Fourth, what is my personal blood pressure target? Not the general guideline printed on a poster in the hallway. The specific number you, my doctor, want me to stay below given my age, my health, and my medications. Fifth, should I be doing home blood pressure monitoring, and if so, how often and at what times of day? Write these down, bring them, ask them. You are not challenging your doctor. You are participating in your own care. The doctor is still your partner. But you are not a passive recipient sitting in a paper gown waiting to be told what to do. You are an informed participant in a conversation about your own body. That is the most important shift you can make. Now let me pull everything together. You now understand how amlodipine, hydrochlorothiazide, and metoprolol work inside your body. You know what each drug targets, what side effects to watch for, and the warning signs that mean something needs attention immediately. You know how these medications interact when they are combined, what foods and drinks silently undermine them, and why a single blood pressure reading on a cuff tells you almost nothing without context. You know the questions to ask your doctor, and why asking them is not confrontation but responsibility. This is knowledge your doctor does not have 45 minutes to deliver in a clinic visit. There is no billing code for it, and no time slot that fits it. That is exactly why this channel exists. If you found this useful, subscribe to Dr. Johnson, hit like, and share this video with someone you know who takes blood pressure medication. They need to hear what you just heard. Every subscriber helps this information reach the next person who is swallowing a pill every morning without understanding what it does. And remember, that free health screening link is in the description. 30 seconds could make a real difference in what happens next for your heart. Take care of yourself.